This episode of Pupil Pod is supported by Dompe.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Dan Choi. Dr. Choi is a cornea and refractive surgeon in Honolulu, Hawaii. Dr. Choi, thank you again for joining me today.
Thanks so much for having me and accommodating this large time difference we had.
Yes, I keep saying 7 p.m., but really that's like 1 p.m. for you.
You caught me in my lunch break here. It's perfect.
Well, thank you for taking your time to do this. Let's jump right into it. So you have a 65-year-old woman with blurry vision that is worse in the morning and a recent diagnosis of Fuchs Endothelial Dystrophy. She comes in for a second opinion about corneal transplantation. She would like to know more about her options and has found some differences in the corneal transplants to be very confusing. Dr. Choi, let's start with full thickness transplantation or penetrating keratoplasty. What are the overall steps and indications for a PK?
Thanks so much. So I appreciate this podcast because I'm going to definitely have my patients listen to this podcast in the future as a nice little summary of all the different components of corneal transplantation. Just to start off, PKP or penetrating keratoplasty is a surgery in which we remove all the layers of the cornea and suture in a donated cornea from a cadaver eye. The reasons why we may perform a PKP is if there's some sort of pathology that involves all layers of the cornea. Most commonly in my practice, this is patients with a perforated corneal ulcer, keratoconus that involves also the Descemet, so usually patients that have acute hydrops, patients that have severe steepening and scarring and that aren't as amenable for just a lamellar keratoplasty. Just to kind of review for our listeners the different steps of PKP. Initially, when you do a PKP, one of your first steps is to measure out the size of the graft. And then you kind of want to balance the size of the graft in terms of how large you want to make it, between a balance of having a larger graft actually helps reduce the amount of astigmatism. But at the same time, if you make the graft too large and bring the graft closer to the limbal vessels, you're at a higher risk for rejection. And also you're narrowing the angle, so you're increasing the risk of secondary angle closure glaucoma. As far as the surgery, after you measure the size, the appropriate size graft, you would then take your donor corneal button and usually punch out an oversized graft about a quarter to 0.5 millimeters in size. And then you use a vacuum trephine on your recipient patient, turn the vacuum trephine down to usually like 80% depth, and then puncture through the cornea the rest of the way with another sharp instrument, use scissors to remove the host cornea, and then you just suture on your donor corneal button.
This is a perfect episode for me right now because I actually have my first urgent PK as a fellow tomorrow. So I'll have to like really think hard about the different steps and all the different equipment that I need. But moving forward kind of in the time course of a penetrating keratoplasty, how do you decide when and which sutures to remove once the patient has undergone some level of healing?
So the timing of the suture removal is really important in terms of making sure there's good integrity at the graft host junction. So usually at 3 months is when I'll start taking out the sutures. This is all guided by your topography. The sutures will cause a steepening in that axis. So if you find that there's this particular steep axis, you'll remove sutures in that axis. Another good rule is try not to remove sequential sutures. Let's say it's early on after a corneal transplant, you remove a few in a row and you actually have a dehiscence of the wound in the area that can be a problem. So I try not to take out sutures that are next to one another. The overall process usually is done over several months. So after that first 3-month visit where I take a couple sutures out, I'll continue to take sutures out every 1 to 2 months. And then I actually don't take out every suture. It's really based off of the patient's final corneal topography and astigmatism. So let's say they have 4 sutures left, but they're actually seeing great. I'll leave those sutures in for an indefinite period of time. And then specifically for the technique for how do I remove sutures, I just do it in the clinic. I put in a betadine drop, lid speculum, and use a 30 gauge needle to cut open cut the suture and just a jeweler's forceps to remove it. I do keep the patients on antibiotics for about 3 days after the procedure is finished.
And what are some of the postoperative complications of PKs, and how do we kind of manage them in clinic?
So for all corneal transplants, I like to think of the complications in terms of timing. So complications can be either related early on, directly related to the procedure and the different steps. So an early complication might involve primary graft failure. So by definition, this is when you sutured on the PK and you waited generally up to 3 months and the cornea is still not clearing. And we usually attribute this primary graft failure to complications during the surgery, such as perhaps the endothelium was in contact with the iris for too long, or any other intraocular lens or a glaucoma tube. Or it could be an issue with the procurement of the tissue, like something happened during the transfer of the tissue. For me, that's a big concern because I get my tissue shipped in from usually from Washington and California. So I really want to make sure that the freight shipments and everything went okay. Other complications that can happen early on are really related to your suturing. So patients can get wound leaks, they can have loose sutures. Um, Another variable, usually related to suturing and how well you oppose the graft-host junction, is delayed epithelial healing. If there's a big gap for the epithelial cells to migrate from the limbus onto the donor cornea, you might get a patient with a persistent epithelial defect. Other things that could contribute with that is if you have somebody that has exposure issues, is a chronic eye rubber, especially like your keratoconic patients. If you do a PK, sometimes they'll have delayed healing because the same habitual habits that led to all the ectasia is also denuding the epithelium. For those patients, you want to consider for patients with delayed healing, you want to consider putting in a bandaged contact lens, patching them, or even using an amniotic membrane if it's necessary. The most feared immediate postoperative complication would be endophthalmitis. Just like every other eye surgery that we do, the biggest concern is getting infection inside the eye. To prevent endophthalmitis, it's really a process of making sure the whole process of procurement is stable, and that any preparation that you do in the OR is sterile, not stable, sterile. Just as a precautionary measure, I'd say that every corneal surgeon will send their donor rim for culture, just in case something grows back and then there is an infection. You can identify the source of the infection. Uh, so outside of the immediate complication risks, some of the long-term complication risks that we're looking at are mainly to do with episodes of rejection. So rejection, just as an overview, rejection most commonly occurs after the first year of transplantation. We see this because after a year, you're usually tapering these patients off of steroids. Some patients will stay on steroids indefinitely, once daily, but some surgeons, depending on the patient's response to steroids in terms of intraocular pressure or their ability to comply with the drops, might take them off steroids, and that's when you usually see more rejection episodes. Graft rejection is categorized usually by the anatomical location. So graft rejection can be categorized as epithelial rejection. So it's at the epithelial layer. You'll usually see like an epithelial ridge, and you'll see some adjacent limbal vessels that are injected. This really represents a vast majority of rejection episodes. It's only about 2% in the literature. And honestly, I don't think I've seen an epithelial rejection episode before. The next category would be a subepithelial rejection, which looks like a bad case of EKC, meaning you'll see subepithelial infiltrates scattered throughout the cornea. So I think that's a really good tidbit for any fellows or residents that are covering call. You see a patient that has a history of PKP and they come in and you think it's just EKC. The treatment's similar in terms of using steroids, but you would want to be a little bit more aggressive for these patients because you're trying to make sure that the rejection episode doesn't continue and damage the endothelium at the end of the day. Other categories of rejection include stromal rejection. These patients present with stromal infiltrates. And then the final category of rejection is endothelial rejection. This represents about 50% of the rejection episodes, and this is the one that has the worst consequences because it's going to cause you to lose the loss of endothelial cells. On exam, you'll see precipitates on the endothelium. We call that like a Kodos line. And then you'll see stromal thickening because there's decreased endothelial function. And I think for just to review how we can manage these complications, so to try to manage these episodes of rejection, it's all about immunosuppression. So these patients are going through rejection because the bodies recognize the antigens in the donated cornea and try to fight it off as a foreign substance. So you're really trying to decrease the immune response by generally giving steroids. When I was in academics as a resident and fellow, our protocol would be get these patients on IV salmeterol or oral steroids. In clinical practice, in Hawaii, I generally just give a subtenance Kenalog. I think it's a little bit cleaner in terms of not having to worry about some of the systemic side effects that these patients can experience. And then also I'll increase their topical steroids. So it covers most of the complications. I guess the other long-term complication patients can have is late graft failure, or basically the graft kind of runs out of time. So if you think of a patient that has keratoconus and gets a PKP in their 20s, I generally say that they'll probably need 2 grafts in their lifetime. The graft will last 25, 30 years if it's if the patient's compliant, has a good follow-up, and doesn't have any other intraocular issues. So late graft failure is basically over the lifetime of the graft, then the endothelial cells will die off and a new graft may be needed. Of interest for these patients that have had PKPs and they have late graft failure, I'll usually recommend doing an endothelial graft underneath their PKP, because you're reintroducing less antigens, you're reintroducing less foreign corneal tissue, and these patients do really well with endothelial graft under their PKP.
Okay, so talking about endothelial grafts and going back to our patient a little bit who has endothelial dystrophy, what are some of the surgical options for her?
All right, so for this patient, and all patients with endothelial disease only, which Fuchs is just an endothelial disease, I would really just offer an endothelial transplant. The reason why I'd focus on an endothelial transplant and not a full thickness PKP is because you really don't need the donated stroma and epithelial cells. Those are things that will just create more problems for the patient. So within endothelial transplants, her 2 options would be either a DSEK, which is where you take a donated cornea posterior stroma, Descemet's and endothelial cells, or a DMEK, which is just the Descemet's membrane and endothelial cells from the donor. So just as a little overview, before 2003, so all the way up until like the early 2000s, almost every graft that we did was a full thickness penetrating keratoplasty. And that was mainly because there weren't as many good techniques to just harvest the endothelium. But in 2003, DSEK was introduced and became a popular technique. And then actually later in 2006, DMEK was introduced, but didn't get really full adoption probably for another decade. So with the introduction of endothelial transplants, we actually do a lot more endothelial grafts nowadays than PKP. We actually do twice as many endothelial transplants as we do full thickness grafts in the United States. And actually the number of DMEKs that we do compared to DSEKs has risen, and they're almost about the same. So over the past decade, there's more and more surgeons that have transitioned or gotten more accustomed to DMEK. Just as a review again, we mentioned that we do endothelial transplants for patients with endothelial disease. Besides Fuchs, this would be a patient that might have bullous keratopathy secondary to intraocular surgery. So patients that have had dense cataracts, glaucoma, retinal surgeries in combination with a cataract surgery as well. Patients with viral endothelial disease, such as herpetic endotheliitis. These patients get recurrent episodes. They lose too many endothelial cells. And even when they're not active with their infection, they might have corneal edema. Other less common conditions would be PPMD, or posterior polymorphous corneal dystrophy, CHED, or congenital hereditary endothelial dystrophy, and then ICE syndrome would be other etiologies of needing an endothelial transplant. And then again, just to kind of review, and as I mentioned earlier, we always prefer endothelial transplants over PKP because of the less tissue involved. And this means that we don't need to cut through the entire eye and have a full thickness wound. So it helps protect the integrity of the eye. That equates to less astigmatism, faster visual rehabilitation, much lower rejection episodes compared to PKP, and better long-term survival. Just as like a real world example for this patient, let's say this is like the year 2003, my options are either a DSEK or a PKP. I explained to her if I did a PKP, we'd work for a year to get sutures out for best vision. But even with that, she might have some irregular astigmatism, might need a scleral contact lens for the best vision. Whereas if we did a DSEK at that time, I expect her vision to clear out within a few weeks. Nowadays, for a patient like her, I tell them I would really much prefer doing a DMEK over a DSEK. Visual acuity is on average aligned better with a DMEK compared to a DSEK. Graft rejection is better. There's about a 1% rejection rate with a DMEK after 2 years, about 10% with a DSEK. So I really push for DMEK for these patients. And this case example is a common patient I get. I'm one of the younger corneal surgeons on the island, and I've done the most DMEK on island, so it's become one of the things I get patients referred for. And a lot of patients do their research and they want to know what's the difference between DSEK and DMEK, and these are kind of statistics I go through with them. Just as an overview of the steps of endothelial transplants, both surgeries, what you're ultimately doing, you're scoring and removing the host Descemet's membrane. You usually use like a reverse Sinski, so like a upward facing hook to kind of score the Descemet's, and then you strip it away. And then the two surgeries mainly differ about how you introduce new donated grafts into the eye. So in a DSEK, you're inserting the corneal lenticle, like that posterior stroma, Descemet's, and endothelium that you have donated, usually through a 4 millimeter incision. So you have to use a slightly larger wound compared to a DMEK. And there's a variety of ways that people insert DSEK tissue. There's actually a technique where you could use just a sheets glide, put some OVD, and you actually just push the lenticle in. A common way that I do it is actually using a specialized irrigating and inserting device called the endoserter. It's called the TAN endoserter. I think it was the famous surgeon in Singapore, Dr. Tan, that came up with it. But basically allows you to irrigate and maintain the anterior chamber, and then you can shoot in the DSEK tissue without as much direct manipulation. Once you have the DSEK tissue in the eye, the DSEK tissue generally orients very well, and it's very easy to manipulate because there's still posterior stroma. So it has a nice rigidity to it. So it usually unfolds quite well, and you can actually usually just tap on the surface of the eye to get it centered. And if that doesn't work, you can actually go in and grab an edge of the lenticle with your reverse Sinski to manually position it. Try not to do that, but it's always an option to get things into place. So positioning and getting a DSEK centered is usually not an issue. It's usually much more, it's much easier from a technical standpoint. In a DMEK, on the other hand, and why it took some time for adoption, the DMEK tissue is just the Descemet's membrane and the endothelial cells. So you're working with a much smaller amount of tissue, and the tissue is very fragile and friable, and it doesn't like to be touched, and you generally just don't touch it. As a result of having such a friable tissue, generally we use DMEK tissue from older patients because their Descemet's membranes are thicker, so it's a little bit easier to manipulate. For these patients, the DMEK tissue is generally stripped and then floated in BSS, and they're usually drawn up into some sort of injection device. Some people will use a modified IOL cartridge. The common thing to use now, what's commercially available through CorneaGen, I don't have any financial disclosures, is a preloaded system. So it's actually a Gutter cannula. So it's actually this glass tube that has a tip that fits inside a 2.4 millimeter wound. And the tissue is pre-stripped, it's pre-punched and pre-stamped. So everything's like loaded up in this little tube, and you connect that to a 1 or 3 cc BSS syringe, and then you go through a 2.4 millimeter wound and you just shoot that into the eye. And it's really, really straightforward. And I think it's a great way for for surgeons to transition into DMEK. I'm sure a lot of people that are in academics or in training, you guys are probably still learning to strip and prep the tissue yourself, but out in private practice, someone else usually takes care of that for you, either your local eye bank or one of these larger commercial entities. Getting back to the DMEK technique, DMEK's really challenging from a technical standpoint of centering it because you have this tissue that's rolled up on itself. It doesn't want to unfold on its own because that's just not the natural configuration of that thin tissue. And you can't go in there with a Sinsi hook and drag it into place. So again, this part would be like a really long lecture, and it's a great thing to attend at AO or Ascaris if they ever have a wet lab for DMEK. I think that's one of the most helpful things I did right after training. I actually took a course, the first AO after training, to sharpen my DMEK skills. But long story short, with DMEK, you try to flatten the AC as much as possible. So then there's less space for the DMEK tissue to stay in a tight scroll configuration. You can actually use the iris to kind of flatten out the DMEK tissue. And then you use a series of taps and pressure gradients by essentially flattening the AC to a further extent to try to flatten the DMEK and get it to open up, and then you eventually put in a gas bubble. For both of these transplanted tissues, the tissue is going to be marked to help you get oriented to make sure your graft is not upside down. So usually the traditional mark is like an S mark. Some eye banks will put an F mark. There's some eye banks that will put a peripheral notch to help you orient. I guess some say it's like a shark fin notch, or there's a certain orientation to it. I think that would just be confusing to me. I think the letter's a little bit easier to read. At the end of both cases, your ultimate goal is to have a graft adherent to the recipient corneal stroma. And in order to do that, you have to put some sort of tamponade. So for DSEK, traditionally put in air, and the air bubble will float that DSEK tissue into place. For DMEK, since that DMEK tissue is more fragile and more likely to unscroll and kind of fall off and dislocate, we generally put in 20% SF6, because 20% SF6 is non-expansile and usually stays in the eye for 4 to 7 days. And then over time, the goal would be the graft is in place, the endothelial cells wake up, and they start, naturally adhering themselves to the host corneal stroma, and then you have a patient that can see well. So that's it's kind of a loose review of both surgeries there.
This episode of Pupil Pod is supported by Dompe.
No, it's extremely helpful. Even the part about shallowing the AC, I think, is good to know as a younger surgeon trying to figure out what works and how to best get the graft to stick. So I know that we prefer EKs, obviously, to PKs in any situation where the cornea would be amenable to that. But what are some of the complications that are associated with endothelial keratoplasty?
Yeah, definitely. So for complication of endothelial keratoplasty, really majority of the complications you'll face are related to the technical challenges of it. With both techniques, you're trying to get a graft to be centered. So for DSEK, you might have difficulty if the patient has any kind of abnormal anterior chamber pathology, like there's a glaucoma tube, or they have like an ACIOL. It can become more difficult to get that graft to be centered. And then for DMEK, the same type of challenges exist where centration. And then for DMEK, another more common concern is graft dislocation. So there's oftentimes series of or publications where where surgeons will follow their series of dislocation rate over time. And generally, the first 50 cases aren't the best. There's a lot of dislocation because people have a hard time unfolding the graft, and then they have a harder time recognizing if there is a small gap in the early parts of the surgery, or if it's completely attached at the end. For patients that have graft dislocation, your real option is just to rebubble them. This could either be done in the clinic or you could bring them back to the operating room. Things that could help you in terms of diagnosing small detachments. If you have access to anterior segment OCT, that's a great way to help visualize things. And then just kind of some rules of thumb for DMEK dislocations, which are more common. If you have a small peripheral dislocation, I generally leave that alone. Over time, the endothelial cells will start pumping and that'll close down. If you have a large central dislocation, then that's something you generally need to rebubble. Other things to consider is if there's like an inferior 1/3 of the graft that's dislocated, sometimes those will propagate a little bit faster. Because generally speaking, if you have the tamponade will help you up for the superior half of your cornea because the gas bubble obviously floats up and it will give you a more prolonged tamponade. So oftentimes you'll see more inferior dislocations as well. As other considerations or other complications with EK, one unique thing is you're introducing an air bubble into the eye compared to PKP. So you're actually, you can actually get pupillary block. In DSEK, what will commonly happen, these are pseudophakic patients, like the gas bubble can get behind the iris and then push the iris forward and cause iris bombay. In DMEK, one thing like you generally leave a larger air fill or larger gas fill, and the gas lasts longer. And if you don't have the gas bubble clear some sort of passageway from the anterior chamber to the posterior chamber, which is usually an inferior peripheral iridotomy, you're going to get pupillary block, and then the pressures can go up from pupillary block. So for DMEK patients, I generally always put an inferior PI. For DSEK patients, you want to ensure you don't get pupillary block by making sure that their pupils dilate past the margin of your air bubble, meaning whatever airfill you leave at the end of the case, you want to make sure your pupil is wider than that, so then there's passageway of fluid from the posterior chamber to the anterior chamber. One unique complication that's in DSEK that's not in DMEK is you can get epithelial ingrowth with DSEK. I mentioned the wound's much larger in a DSEK compared to a DMEK. And if you're doing like a push-pull technique and you're manipulating cells of the limbus and you have this larger gaping wound, you could get migration of epithelial cells inside the eye. And there's been good reports showing causes of primary graft failure to be epithelial growth, and that's something that hasn't been reported with DMEK. Other concerns or complications that have been brought to light over the past decade. One unique complication, it was something that was identified as a trend in the late 2000s, like 2007 to 2010. They noticed that patients that were getting EK were getting more fungal infections than patients with PKP. The hypothesis was these tissues, these endothelial transplants, need more manipulation at the eye bank and also on the bench for the during the surgery, so there's more time for fungus to propagate. There wasn't a statistical significant increase of fungal infections compared to PKP, but there was a trend towards this. And as a result, most eye banks have added amphotericin B as a way to combat that. So that's one unique potential risk of an EKA compared to PKP. I mentioned earlier the other general risks or general complications with corneal transplants being primary graft failure. So as you can imagine, all that tapping, all that manipulation, you could lose endothelial cells and the graft might not work. And then I mentioned earlier with PKP, there's risk for graft rejection. Graft rejection is a little bit different with endothelial transplants because obviously the only thing that's really rejecting is the endothelial, like the Descemet's endothelial cells. So what you generally see is usually multiple KP. You don't usually see like a rejection line like you do in PKPs. And then I mentioned already that the rejection rates are really low with DMEK compared to DSEK and PK. So it's generally, I haven't really seen any DMEK rejection episodes. So I think that's pretty much everything as far as the complications for endothelial keratoplasty.
That was a really comprehensive review. Thank you. So then I guess our final major topic for this episode is what are some of the newer techniques for endothelial dysfunction? I think it's really exciting to go to these conferences and hear about gene therapy and stem cell therapy, but what about some of the newer surgical techniques?
Yeah, it's a great observation. I think that our field, especially cornea, is constantly moving forward, trying to use less tissue and be more minimally invasive. And something along those lines is a technique called DSO, Descemet stripping only. It's also referred to as desmetorexis without endothelial keratoplasty. And this is really reserved for patients with Fuchs. Um, these are just two terms that describe the same exact surgical technique, where essentially you're just removing the diseased Descemet's membrane that's found centrally and allowing healthy peripheral cells from the patient or even cultured endothelial cells to migrate over that central defect where you've taken out that diseased Descemet's membrane. So DSO and DWEC is something that I haven't actually done myself. So I talked to my co-fellow, who's faculty member over at Bullseye Hospital, to get all the highlights of the procedure. But her highlights were really that the clinical criteria for being able to perform a DSO, I'm going to stick with DSO as a term just to make it simple, is to identify a patient with Fuchs that has guttata. It's only centrally located to the usually a 4.5 or 5 millimeter zone, and they have to have an absolutely clear peripherally clear endothelium. So no edema, no peripheral guttata, because you need a healthy population for the cells to migrate from. As far as the surgical technique, you'll use usually like a reverse Sinski or some sort of sharp instrument to score the Descemet centrally. And it's kind of described as doing a kind of like a capsulorhexis, but you're doing it on the Descemet membrane. And you have to be very conscientious of having nice, smooth, continuous edges because you're trying to encourage migration of endothelial cells. So if you have any loose flaps or ridges, those endothelial cells won't make it over to the central cornea and will stay edematous. So basically, the surgical technique is scoring the middle, making a little flap. You usually use like a reverse utrata or a micrograsping forceps to grab it and wrap it around like you would like a capsulorhexis. Then these patients are usually put on a ROCK inhibitor. The one that's commonly used is ritacidil. It's available in Japan. Patients can actually order it directly to themselves. It's not FDA approved, so that's usually a way of circumventing some of the regulatory issues. We have a ROCK inhibitor in the US, it's Repressa. However, the dosing Repressa is once daily. And I'm sure for anyone that's prescribed Repressa, it causes a lot of redness and ocular irritation. So once you go up to QID dosing, it really, really drops off in terms of compliance. And if you only do once a day dosing, it takes forever for the cornea to clear. So oftentimes people that are doing DSO, they'll order the drops from Japan. So I think that kind of covers DSO as a whole entity. In summary, for DSO, you need someone that has very limited Fuchs just in the central cornea. They need healthy peripheral cells. It needs to be someone that's willing to wait about a month for the cornea to clear. But if they go with this route, they don't have to deal with all the consequences of having an endothelial transplant inside their eye.
So let's say that our patient actually had visually significant Fuchs, but with a healthy peripheral cornea. Which surgery do you think that you would recommend for them? I know that you don't do DSO out in Hawaii, so just speaking towards like what you would do in your clinical practice.
For her, I the only reason I haven't done it, I haven't come across a patient like this in the scenario,
Yeah,
but
like the perfect patient.
yeah, I would for sure offer her DSO. Um,
Yeah.
I spoke with Zabel, she's at Wills, and she said that only about 5% of her patients qualify for DSO. And I always I'm literally on an island here in Hawaii, and also I feel like in private practice, you could do as much as you can going to conferences and reading journals, but it's nice to touch base with people that are academics to see where you stand in terms of keeping up with your skills. And she said about 50% of the faculty do DSO. So I think we're also in a transition point. And if we identify more patients that have a very similar clinical scenario as this patient, I think it would be very appropriate to offer DSO for her. I would actually make the argument for DSO for this patient, saying that, if we don't transplant any tissue, you don't have to worry about rejection. Another huge benefit is you don't have to use drops forever. And steroid drops have complications such as increased risk of elevated intraocular pressure and steroid response glaucoma. So for this patient, I don't see any downside of offering DSO. It would be really my recommendation. I would make it clear to her that the visual rehabilitation will be longer. It will take 4 to 6 weeks for it to clear. With my DMEK patients, if it's a Fuchs patient, once the gas bubble is gone, they're usually seeing well after that first week. But again, I think that small difference in timing is not worth the long-term burden of having a transplant in the eye. So I would much prefer doing a DSO if I was the patient, and that's why I would offer this patient as well.
Great. May we hope that we have patients that have just perfect peripheral endothelial cells, but obviously that's not what we generally see in clinical practice. So let's summarize what we learned. Corneal transplantation can involve the entire cornea and is called penetrating keratoplasty, or you can have partial thickness transplants such as DSEK or DMEK. PKs or penetrating keratoplasties are more common in eyes with diseases like keratoconus or pathology that involves both the endothelium and the stroma, or in eyes with very complex anterior chamber pathology. Whereas EKs or endothelial keratoplasty are more common in eyes with endothelial dysfunction, such as in patients with Fuchs endothelial dystrophy or in pseudophakic bullous keratopathy. Both PKs and EKs can undergo primary graft failure and graft rejection. Now, graft rejection is actually more common in PKs, and the most severe form of graft rejection or endothelial rejection generally presents with precipitants on the corneal endothelium, which we call the K line. And that is, again, much more common in PKs than in EKs. And then finally, we have newer surgical techniques such as DSO that offer the chance of removing the abnormal endothelium in eyes with healthy peripheral endothelial cells, and they avoid the use of donor tissue and rejection. However, like we've been talking about, these are reserved for eyes with very mild to moderate disease. And even in those cases, it takes much longer for those patients to have visual recovery than in patients that had a DMEK. So, Dr. Choi, before we end the episode, I ask all of my patients, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Yeah, I thought about this question listening into it on other podcasts, and I think in the past I probably would have said someone like Michael Jordan or some famous person, but I think it's kind of a reflection of me getting older. My answer would be actually my maternal grandmother. She's actually my mom's mom. And the reason, I know it sounds like a strange answer, but I guess the reason being is she passed away before I was old enough to have any real memories. She passed away when I was like around 2 years old. And by all accounts, she was a really amazing woman and real humanitarian. She was around my age that I am now through the Korean War, and she actually ran an orphanage after the Korean War and like hosted about 80 to 100 kids annually to help offset the burden of like the 100,000 orphans that the 100,000 orphans after the Korean War. And she just sounded like a really great leader and someone that I could learn a lot and gain a lot of wisdom. So I think my young person answer would be like some celebrity where we could have a lot of selfies and have a, like it'd be a real memory in that way. But I think my matured answer is trying to dig through my lineage and learn a little bit more from my past. So
I think that's a really beautiful answer, and I'm sure that you would have just the best food and the best dinner if you were with your grandmother. So, Dr. Choi, thank you so much for joining me today.
thank you so much for having me.
And thank you to our listeners. Hope to see you next time on the Pupil Pod.